At Oak Mountain Academy, we encourage our students to find their niche in any of our 42 co-curricular opportunities. Over the past 5 years, we have brought home 5 state and 20 regional athletic titles. Our one-act play and literary teams continuously compete at the region and state level, and our academic teams bring home first place more than not. We are warriors creating legacies. To learn more, visit oakmountain.us.
At Tanner, we care about your health, so please wash your hands often with soap and water for at least 20 seconds, especially before eating, after bathroom breaks, blowing your nose, and after coughing or sneezing. If soap and water aren't available, use a hand sanitizer. Avoid touching your face with unwashed hands. Clean and disinfect surfaces and objects often. Cover your coughs and sneezes with a tissue or the crook of your elbow. Avoid people who are sick and stay home when you are sick, except to get medical care. See more ways to stay well online at tanner.org.
Good morning. Welcome to the special edition of the Community Voice. I'm Steve Graddick, your host, and delighted to have you with us. We're going to have again, special edition. We have on the phone Mr. Lloyd Howard and Dr. Laura Larson, who we're going to introduce in a second. We're broadcasting on 1330 and FM 106.3. We're on Facebook Live on the News Talk 1330 Facebook page, and this program will be shared to all our other Facebook pages and our YouTube channel after the program. And our topic this morning, of course, is coronavirus and the pandemic and our response with that. Good morning, Lloyd, and good morning, Dr. Larson.
Good morning.
Good morning.
Hey, all right. Everything's working, so I feel good. Lloyd Howard is President and Chief Executive Officer of Tanner Health System. He became President and CEO of Tanner in 1994. He previously served as CEO and CFO of the Union Hospital District in South Carolina, certified public accountant. Dr. Laura Larson is Medical Director of Infection Prevention for Tanner Health System, board certified in both infectious diseases and internal medicine. She earned her medical degree from Mercer University School of Medicine and completed a residency and fellowship at Shands Hospital at the University of Florida. She's on the American Board of Internal Medicine, Infectious Diseases, and chairman of the Carroll County Board of Health. Well, again, good morning. What we'd like to do, we've began with our sponsorship of this program is, of course, Tanner Health System and Oak Mountain Academy, and we played those commercials at the beginning. We'll play them at the end, so we won't be interrupted during the course of the program. So we're going to try to cover a lot of material in a relatively short amount of time, so I'm not going to do a whole lot of follow-up or discussion, and so that we can cover a whole lot of the topics. Obviously, I would think we'd want to start off with Dr. Larson. If you could, give us an update on the numbers and the stats as they, like Tanner, who has hospitals in Villa Rica, Bremen, Wedowee, and of course Carrollton. We too serve a regional area. Can you give us the latest numbers as you know them to be?
Sure, and I want to tell people that I'm going to disclose these numbers even though they haven't been officially reported, because I think it's important for people to know how serious this is right now. We had our first cases Thursday night, and we had been testing for about 2 weeks prior to that time. Our first week of testing was bottlenecked because that's when testing opened up with a major United States and worldwide lab, and we still have over 200 of those tests from the first week pending, so we don't really have a good handle of how many tests were really in the community 2 weeks ago. Our first test that came in delayed showed that we had a positive case in our community 10 days ago, so we know that. But Thursday, and that test just came in yesterday, so that's how delayed that testing was. So Thursday, we ended up having initially 8 new tests that night. So Thursday, Friday, Saturday, Sunday, Monday, fast forward 5 days, and now we have 60 positive tests, of which we believe about 42 were in the county. We have 30 confirmed tests in people in the hospital. So we have 30 patients with COVID-19 in the hospital. 6 of which were on the ventilators as of last night.
I understand.
I want to emphasize,
Sure.
Those are outside labs, so we're really not in control of when they report back. We're really dependent on them to do that. Yeah,
we have, I don't know of any hospitals our size, including Wellstar, which is a bigger system, that has in-house testing yet. We have 2 instruments that are capable of doing in-house testing, and one of those instrument companies just announced that they have the capability of possibly providing us tests next week. And I've had some really smart people say, wait, you guys have a lab. Why aren't you testing these right where you are? The machines that do this are owned by that particular company. You have to buy that particular kit. And most of those particular machines don't have those kits released yet. So as far as I'm aware, the only hospital system right now today that can do in-house testing is the State and Emory University. And I'm not even 100% sure that is the case, but it is not an easy test to get at all.
Can you describe the test itself? I understand it's a little bit invasive going up through the sinus cavity.
It absolutely is, and if you don't do it right, we tell people if you don't feel like you have had your brain skewered, that's kind of a joke. But what you do is you take that swab and go through the nose to the back of the throat. So you're taking that swab down into the throat from the nose. But that is the most effective way to get a real diagnosis if a patient has this particular illness. So we're actually pairing an oropharyngeal swab, meaning swabbing the back of the throat through the mouth, and swabbing the back of the throat through the nose.
I understand they're developing some self-test, or where are we in that development?
I'm not aware of any of that right now. There are a lot of companies that are producing kits, and to be honest, I'm just worried about that, and my colleagues in the infectious diseases world are worried about that because these are kits that I would compare most commonly to like a pregnancy kit, where you prick your finger and put the blood on that, and we're worried about that because even in our labs where we used to use a lot of those point-of-care type tests, with a lot of companies coming out and making those, we don't know how accurate they're going to be. We know that early on in testing, when the state was using point-of-care tests, we have concerns about how accurate all of that is going to be. For all of the testing that's done now, all of the testing is done under emergency use authorization because we have to have them, and we don't. But no tests have been validated yet. So what that means is that you have to have blood drawn on a positive patient, and you compare, did the test compare to the blood? And we don't have that blood testing capability right now, except for in research labs. So that's not what's available to us right now.
Can I say?
Sure.
Do you mind if I'd like to chime in and say that while we, please, Dr. Larson, add to this. While we will continue to do testing, we feel that the urgency of this crisis is really beyond testing at this point. I think that, and Dr. Larson, if you don't mind, I'll turn this over to you. We have enough information to say that this crisis and this virus is out in our community and among our community. And we'll do additional testing, but that's been confirmed with this level of cases.
I think that's absolutely 100% right. When we are calling people and telling them that their tests are positive, they immediately want to test people in their family, and we're counseling them no. And I would not, even if that person tested negative, I wouldn't feel comfortable that result was accurate. This is out. We know it's been out probably 2 weeks, even though right now I have confirmation the first earliest test that has ultimately returned positive was 10 days ago. I have a lot of people asking me, why won't we disclose where the cases are? I can disclose the cases are all over the county. There's nowhere safe. So I don't feel that is good information to tell people where to go, where not to go, because we do have cases all over the county.
So to emphasize that point, you say that with these positive tests, it indicates that the virus has been in our community for several weeks, 2 to 3 weeks, and it's been here. It just hadn't been identified. So my next question is, who do you recommend needs testing? Who should be tested?
I think people that are sick. People that are sick and having trouble breathing. Those are the predominant ones. Also, people that are sick that have risk factors that they may progress to severe disease. And those are diabetics, people with chronic heart disease and chronic lung disease. If we have a bunch of people that are, mildly ill come to the emergency room for testing, they may not be tested. That emergency room is following the same guidelines the rest of the United States is following right now, which is testing symptomatic patients. And if you test someone who's asymptomatic, it's really a false sense of security if they test negative, because they may be really a true case and just not sick enough to be shedding virus. So really, very soon, and I believe exactly what Mr. Howard said, very soon the testing is going to be irrelevant. People are going to be triaged based on symptoms, and the sickest people are going to be the ones that we have to address. Unless something changes very rapidly in the United States right now and testing capabilities ramp up significantly. And I have to stress, even though testing capabilities may ramp up, we can't ramp up the size of the number of ventilators we have. We have had discussions every day on how can we ventilate more patients than the ventilators we have. I read on Facebook somebody today said, well, hospitals should just surge and buy more ventilators. We can't. Everybody wants them. It's not that easy. So this crisis, unless we as a community get better about social distancing, will overwhelm every hospital in the United States.
So, Lori, if you could give us your status, the hospital status, the health system status on your supplies, your ventilators, and what your hospital is doing currently.
Based on our current numbers, Steve, we're using our ventilators at nearly maximum capacity. So we are going to have to think outside the box. We have canceled most of our elective procedures, so we have ventilation capacity, in other areas of the hospital. But it's. Do I feel confident that we will be able to handle every person that needs a ventilator in the next couple of weeks? No, I'm not, and that's just the truth. We're having conversations ahead of time on what we will have to do if we get to the point of having to say 2 patients need a ventilator and we only have 1 left. We're thinking completely outside the box of trying to ventilate multiple patients on 1 ventilator, but that's not that easy. They all have to have the same oxygen requirement. They have to be kind of the same size patient, same lung volume. It's just overwhelming to think about having to do that, but we're actively doing that, and we are preparing for that possibility. I've been at this hospital for, 15 years, and I've never been more proud of our medical staff, because anesthesia, the hospitalists, the critical care doctors, the pulmonary doctors, the ER doctors are all on the same phone call at 10:30 a.m. every day trying to figure out how we can prepare for the worst possible scenario. But I just need the community to do the other part, which is to not go out unless it's essential, to not be around other people within their 6-foot bubble. I guess that's my fear, is people just aren't hearing that message at all.
Yeah, we really need near total cooperation from the public to beat this virus. That means you stay home and you stay out of public places. If you have to be in public places to get food or to get gasoline, social distance. But this is not normal activity. That is the only way, really our only hope, that we don't overwhelm our capabilities within the hospital. I also want to give a big thank you and shout out to all our nurses, and all our staff that are going. They're going in every day when their children are at home to work and to take care of these patients and go through the everything's required to deliver care in a normal time, but especially in a time like this when you have such a virus like COVID-19. So we're proud of them. I'll touch on that. Our protective equipment, personal protective equipment called PPE, is where our stocks are pretty good. We've had an outpouring of support from the community. We've had people coming in from construction companies, from dentists, from power companies, bringing us masking, bringing us supplies they had. And sometimes they're a little. We had a chicken farmer bring us 10 masks in, and it's been a wonderful outpouring, and those have added up. So those have helped, and we're working 24 hours a day to be sure that our caregivers, our nurses, and our physicians have the protective personal equipment they need to fight this virus, and that's an ongoing thing that we're really focused on also.
I understand Tanner Health System has restricted greatly visiting hours to patients in the hospitals.
Yes, we've gone essentially to no visitors. Is that correct, Dr. Larson? We did.
Yes,
that's
it
effective
is
today.
Yes. And, obviously there will be extenuating circumstances that need to be held on a case-to-case basis. And we are conscious of that and working on that. But I need for people to understand that we need to minimize people coming in and out of the hospital because that's a mode of transmission as well.
For those of you just tuning in, we have a special edition of Community Voice with the CEO of Tanner Health System, Lori Howard, and Medical Director of Infection Prevention for Tanner, Dr. Laura Larson. I think I hear from both of y'all that you really want to emphasize social distancing. I guess in a way to elaborate a little more about that. Why 6 feet? What's magical, if anything, about 6 feet? And just elaborate, if you will, because I hear that y'all really want to push social distancing.
Sure. See, the main method, we know that this virus is spread of one of two ways. We know it's respiratory, so that 6 foot bubble, more or less, is how far can I cough or sneeze and spread infection? And that has been medically studied, and that's the 6 foot recommendation.
Back on real quick on the symptoms, I understand that it's not just upper respiratory symptoms, but digestive, even smell and taste can also be symptoms of coronavirus. Is that true?
Yes, it is. It seems to be a virus that we see more nausea, vomiting, diarrhea with than typically we would see with flu. We don't see those symptoms in every case. And this anosmia and not being able to taste and not being able to smell are kind of newer symptoms that we're hearing about. The problem is that no one symptom is present in every single case. It would be fantastic if we could use one marker and say, oh, that makes someone more concerning to be a real case, but there's no one symptom. Probably the symptom that is present in many of the cases, about 88% of the cases, is fever. But we know even from investigations of our own cases that some folks we've tested, I know of at least 3, have not had fever. So it's very concerning that we test people with symptoms enough to be tested. But what scares me and what I want to stress to the public is there are some people that have very mild symptoms that until they were tested were still out and about in the community. And we even have some people that we have people that were tested positive that their family members did not isolate themselves either, went out into the community, and some of those family members have gotten sick too. So I can't stress enough how it's important for us to isolate ourselves because you may not realize you have it potentially until it's pretty significant that you do, but you were still infectious during a time where you just weren't feeling quite right.
Dr. Larson, don't you think it's fair to say that our position as of this morning is to stay at home, shelter at home, everyone, shelter at home? That is the only way we have any chance to end this crisis and get past this and get this virus to peak in our community and start to begin to get back to a normal life. If we don't do that, it will be prolonged, and the impact on everyone is going to be greater.
Do y'all have
absolutely?
Do y'all have
you
a timeline?
To think about, businesses are worried. They don't want to shut down. Be thinking about ways that you could still do your business but not contact people. I have a friend that has a store. She called me last week and asked me, should I shut down? I said, is it possible for you to do online orders or have people call in orders and do the transaction right out the door? That's how we're having restaurants do business right now. There are ways to think around making your community safe and making it safer for you in the community. I have people ask me all the time, what's the most effective, can you give me some medications to prevent this? Because there's a lot of information about our malaria and rheumatological drugs out there, which we don't have good evidence they're proven and effective, despite what you read on Facebook. I read one of those reports this morning. But the only 100% effective way to not get sick is to not be around other people. And I realize for some people that's devastating. I have a lot of people with mental illness that have called me and said, this is going to be devastating for me because I can't be around people. I really encourage people to try to use their social mechanisms, calling, FaceTime, because that I think is going to be our new normal very soon unless we do more to stop the stem of infection right now.
Do either one of y'all want to engage in a timeline speculation as how long this could last?
It really depends on how good people are about distancing. It really does. My personal thought is I don't think this is going away for months.
Dr. Larson, you mentioned treatment, and we haven't talked any so far about the current treatment. I've got a couple of questions along that line. What is the current treatment for coronavirus patients?
Well, every potential treatment we have for patients is experimental. So the treatment that I feel the most comfortable about is the remdesivir because we have clinical trials going on in the United States about it. You can't just order that. That is not something you have in stock. The patient has to be significantly ill enough to get it, meaning the patient already has to be on the ventilator, but they can't have other comorbid conditions like kidney disease that's advanced, liver disease that's advanced. There's a very fine window of who is a candidate for that drug. So when you have a patient that meets those criteria, you call the company and you fill out a form online, and you can get the drug via compassionate use because it's not an FDA-approved medication at all. We have treated one patient in our hospital with that. So the other medications that we have that are possibly, there's no study that says that these drugs are effective. So there's chloroquine, which is an anti-malarial drug. There's Plaquenil, which is a rheumatological drug. And there is azithromycin, which is an antibiotic, and then Kaletra, which is an HIV medication. Chloroquine and Plaquenil, the first two, show some activity in a test tube against the virus. But it's a very different situation, obviously jumping to something working in a test tube to a person. China has put out some data that they feel like there may be some benefit of these drugs, but it's not significant. The CDC walks a fine line. I'm saying other countries have recommend use of these drugs in patients with COVID-19. The New England Journal of Medicine came out last week with a study of 200 patients showing no real clinical benefit to Kaletra, which is the HIV medication. And the azithromycin information is just being used in combination with the other drugs. So the bottom line is we don't really know. And we had unintended consequences of all hospitals are looking at these things and trying these things, but the unintended consequence is that patients with rheumatological diseases, real diseases, can't get their normal medications. So that's an ethically hard decision. Do we go ahead and take these medications away from our rheumatological patients that have real diseases and treat people with it. I personally feel like if somebody's critically ill, I feel like treating a critically ill patient with those medications is important. But what we're hearing of happening in the community is, and not our community, but all over the world, is that people are just writing for these drugs for people that don't even have known infection just to have. So it's a lot like the mask situation, whereas everyone's gone out and bought masks, and now they're hard to find for all of us. And so that's the same thing has happened for this medication. A lot of people have this medication on hand that actually don't have illness.
Steve, may I ask
Dr.
Larson a question?
Sure.
Real quick. Dr. Larson, could you touch on the age groups? Because it seems like this is considered maybe just the elderly at risk. Could you talk about how this is impacting younger people?
Yes.
COVID-19?
Yes. And when this all came to the surface for us a couple of weeks ago, the numbers we concentrated on were people who die. And we know from the early numbers that if you were over 80, you had a 1 in 6 chance of dying, whereas if you were under 50, your chance of dying was very, very low, usually less than 1%. What we didn't know and wasn't out there then is that young people are getting very sick. Over half of our admissions right now are under 60. The people that I know, the first 2 people that were ventilated in the ICU were in their 50s. We are having young, healthy people being put on the ventilator, and while they may not be dying, they're spending weeks on the ventilator, not days. And most of the time when we put people on the ventilator, it's just a couple days. So if you can imagine that from a physical level of what laying in a bed and being hooked up to life support does to your body, it's terribly disabling. If I were put on the ventilator at age 49 for 2 to 3 weeks, I would be completely disabled once I was well. So it's not, even though we are not seeing as many young people die, we're having young people getting tremendously sick. And we can't necessarily predict who that's going to happen to because we're having young people really sick that don't have the conditions that predict that you're going to progress or die.
When we hear the mortality rate, how should we interpret those, whether it's 3% or point something percent? Is that a good indicator? Because we don't want to not focus on those that recover, because that's a very strong positive.
Yes. So it depends on the situation. I can tell you that Georgia's mortality of about 3 or 4% right now, I think, is real. But I think that's skewed by the fact that we're testing sick patients only because that's all we can do. So I think that, case fatality rates for any pandemic originally, in the beginning are high. And those numbers go down once we're able to test everybody and figure out who actually had milder illness and recovered. So that's how I would explain that, is that the testing capability in the United States is not able to accurately identify the death rate right now. But I can say that, for someone that I love, one person dying that I love from this because they were careless about social distancing is enough. And I'm just, people ask me when I think we're going to have someone die. I think it's going to happen very soon in our community.
I understand heat and humidity is not a friend to this virus. Can we be optimistic that when temperatures and the humidity comes to Georgia, that things will improve?
I hear that, but it is warmer in other countries like South Korea, and I don't really know. We won't know until we know. I hope so.
All right. Obviously, you've spent your medical career studying infectious diseases, and whether it was Ebola, and now we hear about the wet markets in Wuhan, China. This thing of slaughtering and eating these wild animals and the virus transmitting from them to humans, is this something that are you consistent with that origin declaration, and is this something we're going to be facing for years to come?
So we know that the origin of this virus is contained in a large population of bats that live in China. Whether or not it's from eating the bats or not, I don't know. I've read that. I don't know. I know that there are in China that there are markets and people that have close proximity to animals. So these viruses can jump from animal to animal and then sometimes to human. And if that virus is successful, it can cause transmission of disease from human to human. So I think that this will always be a possibility for us as humans because these animal viruses can mutate and become infectious to us at any time. So, yes, I think this will be an ongoing problem. I'm surprised that it's happening with more frequency than it has. When SARS-CoV-1 happened years ago in 2003, I remember I had just finished training, and I was like, wow, great, this is my first pandemic, it's too fast. But we are having a lot of, 5 major infectious scares since I've been out of training, and that's a lot. And this is definitely the one that scares me the most. Ebola scared me a lot, but I never thought we'd really see a case in our community at all. But this one scares me a lot because we have 60 cases in our community, and we just started having those for the first time last Thursday. So that's a pretty fast uptick.
Well, with only just a few minutes left, I kind of wanted to conclude and back to emphasizing social distancing. In a way, from what I'm hearing from both of y'all, is that personal responsibility and personal sacrifice is the order of the day. It seems as if y'all are really emphasizing that, which makes us think that at the moment the medical community can only do so much. So if you would, as we close out, if you'd like to go ahead and kind of emphasize that, I guess in a sense, kind of like in World War II when everybody on the mainland, came together and sacrificed. If you would, just kind of take us out with that.
Steve, let me do that first real quick, and then I'll leave the last of the time with Dr. Larson. I think that every crisis has its heroes. And clearly, the heroes in this crisis are our physicians, allied health professionals, our nurses, and all our caregivers. They are going in and taking care of these patients in difficult circumstances. And so what I would ask is if you know one of those groups, thank them. And the best way you can support this effort and make a difference is to stay home.
So right now, the only effective treatment we have is social distancing. Dr. Carlos Del Rio, who's the chair of the Emory program that manages pandemics, he said this week, social distancing is our vaccine. That's the only one we have right now. Remember that social distancing doesn't mean that you have to stay in your house. Right now, I would recommend that people can walk around and enjoy being outside, stay 6 feet away from other people. Social distancing doesn't mean cooped up in your home at this moment, and I hope that we never get to the point where you can't be outside and enjoy yourselves, because a lot of people mistakenly think that that's exactly what that means. Social distancing is being away from other people and where people congregate.
I want to thank this morning Loy Howard, President and CEO of Tanner Health System, Dr. Laura Larson, Medical Director of Infectious Prevention for Tanner Health System, and of course we want to thank all the medical care providers that are on the front lines of this pandemic. And we never even, when there's not a pandemic, I believe we really don't thank them enough anyway. And so we ask you to share this program, which is on our News Talk 1330 Facebook page, which will be shared to all our different radio station Facebook pages, including our YouTube channel. And with that said, I hope we can do a program like this every Tuesday. I think it's very valuable. And again, I know y'all are very busy, and there's a lot for you to address. So getting information out to the public is one important part of that, we believe. So, Loy and Dr. Larson, thank you so much.
Thank you.
Thank you.
And you've been listening to the Community Voice here on WLBB Carrollton, brought to you by Tanner Health System and Oak Mountain Academy.
At Tanner, we care about your health, so please wash your hands often with soap and water for at least 20 seconds, especially before eating, after bathroom breaks, blowing your nose, and after coughing or sneezing. If soap and water aren't available, use a hand sanitizer. Avoid touching your face with unwashed hands. Clean and disinfect surfaces and objects often. Cover your coughs and sneezes with a tissue or the crook of your elbow. Avoid people who are sick and stay home when you are sick, except to get medical care. See more ways to stay well online at tanner.org.
As a graduate of Oak Mountain Academy, I've found that my experience on the mountain prepared me beyond all expectations. As a junior at Auburn University, I approached my studies with great confidence thanks to what I learned at OMA. When I think back on my time on the mountain, I think of my teachers. Their genuine love and concern for me as a student was always evident, and now, as an adult, I still foster those relationships. I'm Carly Robinson, an Oak Mountain Academy alum. Visit oakmountain.us to see how you can offer your child an amazing opportunity to be a warrior.
National headlines and the